Heart disease is the #1 killer in the United States and in the world. In heart disease, blood vessels which look like this slowly start to accumulate lipid plaques in their blood vessel linings. This not only narrows the blood vessel, increasing blood pressure, it also encourages clots to form. And if a clot were to, say, block a blood vessel in the heart, a myocardial infarction, a heart attack could result. If this occurred in the brain, then a stroke would result. This could happen elsewhere in the body as well. Now, this is a complex process, and that is kind of the purpose of this playlist of videos. For my students, I emphasize that this is a multifactorial trait. There are multiple genes involved. There are multiple environmental factors involved. And then very often it depends on which combinations that you have. Say a good gene might compensate for a bad environmental factor, or a good environmental factor might compensate for a bad gene. And so that is the goal here. I'm going to go through this quickly as an overview. Obviously, each of these videos can go through the individual points made in greater detail. And so once again, the #1 cause of death in the world is that blood vessels change to the point where they now look like this. They narrow because of these lipid plaques. And if a clot were to form or lodge here, then that blocks blood flow in a way which can interfere with cells getting their oxygen, their glucose, and can result in their death. Now, obviously, cholesterol is involved. And so I'd like to just kind of begin with, well, how does cholesterol get to those linings? When we eat cholesterol in our diets, like all of the larger lipids other than short chain fatty acids, it then forms chylomicrons, a lipid protein ball in the cells of the small intestine. And it is these chylomicrons which then get absorbed first into the lymphatic system and then into the blood plasma. As these chylomicrons travel the body, they meet enzymes which are in endothelial cell linings known as lipoprotein lipase. This interacts with those proteins. They'll come up again in a second. That's why I named them. After this has happened, the liver cell will then bind to the remnant of the chylomicron. It sucks it into the liver cell, replaces one protein for another, and then spits it out as what's known as a VLDL, a very low density lipoprotein. There are different classes of these lipoproteins in the blood, and they're classified by density as VLDLs, LDLs, and HDLs, and then a couple other intermediates. So this process then continues. The VLDL then goes throughout the bloodstream. Fatty acids are liberated. And so the VLDL gets smaller and smaller as more and more fat leaves it. It becomes an IDL. The liver sucks it up again and then spits it out for a final time as what's known as an LDL. By this point, all of the triglyceride is essentially replaced, and it is now primarily a bowl of cholesterol with apolipoprotein B here. And so this LDL then goes into the blood plasma, and it binds to LDL receptors. These LDL receptors can then absorb the LDL particle into the cells of the endothelia, and then from there to body cells. Cholesterol is an essential molecule of the body. So many things are made from it, and it is incorporated into cell membranes. And so this is not bad, this process of forward cholesterol transport. Once again, cholesterol is essential for life. However, it can occur in some individuals differently than others. So that blue protein was apolipoprotein B. In some individuals, it is mutated or it has a variant form, and this variation can now increase heart disease. That's a genetic reason. There are environmental reasons which could have effects. So for example, if you add more fat in your diet, if you had diabetes or metabolic syndrome, which can be influenced by both genetic and environmental factors, there would simply be more of these LDL particles in your blood plasma. If you had a mutation in your LDL receptor, as I'll cover later, then it might not remove LDL particles well from the blood. This is the most common cause of familial hypercholesterolemia. And so the point I hope I'm beginning to make, and will gradually make further, is that even just this one process called forward cholesterol transport, taking cholesterol from your diet to your body cells, involves multiple genes, you saw those different proteins, and multiple environmental factors. So while all of us have this process occurring in them, that it can occur in different ways in different individuals. And so LDL particles, they are important in this. And then I go through this video, which just gets a little more detail about specifically what is in the LDL particle. There's that apolipoprotein B100, and then some other proteins. There are cholesterol molecules. And so, this video it gets a little more technical as far as what's in an LDL particle. If you are interested. Now, one of the things which will come up in just a few minutes is that the lipids here can oxidize. They can react with oxygen, and that changes the dynamics, but I'll get back to that. So forward cholesterol transport is the process through which cholesterol is taken from our diets into our endothelial cells and thus body cells. However, there is also a process called reverse cholesterol transport, where we can take the cholesterol of the cells in the endothelia, and then through this pump here, it's an ABC transporter, pump the cholesterol into this HDL particle, which then will effectively remove cholesterol from the body, because the HDL particle will then take it to the liver, and the liver then can excrete it in bile. So while forward cholesterol transport is potentially increasing the number of cholesterol molecules that might be incorporated into a plaque, this reverse cholesterol transport is removing cholesterol. Once again, there are proteins in the lipid particle itself, and then proteins which interact with it. And so the question then is, how many HDL particles are in your blood? Well, it turns out that can vary genetically. So for example, some individuals with disease don't make this purple pump. They can't pump cholesterol into these HDL particles. So that would be an example of a gene affecting this. That red protein represents apolipoprotein E, which I'll mention later. But one form of the apolipoprotein E gene, the E4 form, increases risk of heart disease. So there are genetic variants where reverse cholesterol transport might not happen in one individual like that of another individual. But then there are also environmental aspects. So for example, increasing the amount of exercise you do can increase the amount of HDL particles. So the point that hopefully you're starting to realize as I start going through these various processes, which might seem a little bit random. I'll talk a little bit about this, a little bit about that, but hopefully you realize, oh wow, there are a lot of separate body processes which are contributing to heart disease risk. As a result, there are a number of genes contributing, a number of environmental factors contributing, and so as a result, Heart disease, it isn't one disorder, because in this individual, it's caused by a mutation in LDL receptors, which affects forward cholesterol transport. In this other person, it's caused by a mutation in the ABCA transporter, which affects reverse cholesterol transport. In this other person, the genes are normal. It's the high fat in their diet, which is increasing the number of LDL particles in forward cholesterol transport. In this other person, it might be the lack of exercise, which is reducing the number of HDL particles. So hopefully you realize this is complex, lots of processes, and then the heart disease in one person could vary from the heart disease in another person in its cause and its attributes, etc. And this is just beginning, but hopefully you start to realize, oh, that's the big picture that we're ultimately shooting for. So just to continue, I mentioned cholesterol and fatty acids. Well, these are not just things that we can have in our diet, but they can also be made in our bodies. So we have lots of genes which make cholesterol. We have lots of genes which make fatty acids. And often when our body eats less, when we eat less, say, cholesterol, our body often responds by then just making more. And so very often diet alone cannot be used to reduce blood cholesterol levels. And so then the question, if these are all genes, just as our genes for hair vary, the color of our hair, the color of our eyes, all of these other attributes we can see on the outside, they vary from person to person because of genetic variations. Then genetic variations in these vary as well. So some of us make more fatty acids in our own bodies, regardless of what we eat, than others. Some of us make more cholesterol than others. And so there are factors which affect heart disease, which involve cholesterols and fats. But then there's more. So for example, as we will see, white blood cells going into the blood vessel lining and absorbing fats there, that is a big part of the problem. And so you could ask, what would cause this process? Why would, say, these monocytes, which then become macrophages, so let me just call them macrophages, why would these macrophages leave the blood? Because as we will see, that a patient who has a lower risk of heart disease, their macrophages will not go into the blood vessel wall, where it will contribute to a plaque, while the patient with a higher risk of heart disease, they will. So what causes that white blood cell to come into that blood vessel? Well, as we'll start discussing, one of the factors is reactive forms of oxygen. So I'm sorry, this was meant to say ROS, but the smoke is interfering with that. So there are reactive forms of oxygen which will damage endothelial linings and thus promote the migration of the white blood cells. Reactive oxygen species can come from air pollution, hyperglycemia, high blood pressure, advanced age smoking, a whole bunch of ways. And so when we look at the lining of our blood vessels, we vary. All right, so your lining of your blood vessels may be different from mine based on how much inflammation is occurring, whether you have high blood pressure, whether you're exposed to air pollution, we'll get to those in a second, whether you have high blood sugar, you're in advanced age, etc. And so this, all of these processes can damage the endothelial lining of the blood vessels in a way which will change how white blood cells start plaques. Now, I review that again. So here's a video on those reactive oxygen species. There are also reactive nitrogen species. And then there's also antioxidants. There are antioxidants which we make in our body. There are antioxidants which we ingest in our food, such as vitamin C, vitamin E. And so if the reactive forms of oxygen are a factor in heart disease, then there are a number of genetic and environmental reasons that the levels of reactive oxygen species might vary from person to person. Now, just to say something. I know when a lot of us hear the word oxygen, we think, oh, well, isn't that just this wonderful molecule? I can't get enough of it. And the answer is no, that is not true. While oxygen is essential for life and we need it, too much of it will kill you. So for example, if someone said, let's go scuba diving and I'll give you a tank of pure oxygen to start breathing at a deeper level, you say no, because you'll die. Oxygen not only rips up our food, oxygen rips up lots of types of molecules, including the kinds we like. So reactive forms of oxygen are lethal and are a major factor in a lot of disorders, from heart disease to asthma, etc. So please don't just assume that oxygen is just this wonderful molecule. We certainly need it, but reactive forms of oxygen are a major factor here. So, as we will see in a second, white blood cells can ingest lipids which are starting to accumulate. They can ingest LDL particles. Now, if they are oxidized, so fat cholesterol particles which then react with reactive forms of oxygen, they change. They become different than a regular old LDL particle. So once again, we start getting into some variation. So for example, this is stereotypical a little bit, and I hope I don't think I offend. But for example, if one were to compare, say, my risk of heart disease to an Eskimo, living under, the cultural conditions where, they're hunting, a lot of, meat and, walruses, whales, etc. Well, you might look at that Eskimo and say, well, part of the diet is blubber. That's certainly a high fat diet. Surely I would have a lower heart disease risk than that Eskimo. And that's not necessarily the case, because LDL particles can have cholesterol, but oxidized LDL particles are different and have a much greater effect. So you could have less fat in your diet than another person. But if, say, air pollution or smoking then oxidizes these LDL particles, these oxidized LDL particles could have a much greater deleterious effect on your health than LDL particles which have not been oxidized. Some components here can actually change the expression of genes in white blood cells. Right? And so there are genes which bind to DNA and turn on gene expression. There are fatty acid components of oxidized LDL particles which can react with a receptor which is made within cells and actually change which proteins are made, and then even which RNAs are made. So not all RNAs become protein, but nevertheless a lot of RNAs then have an effect on the cells. And so a white blood cell which has oxidized LDL particles in it, it's making different proteins and RNAs than a white blood cell that doesn't have oxidized LDL particles. So in this video, that kind of emphasizes the same thing. If you just have these yellow LDL particles, they can be absorbed across the endothelial lining, but then they can then form HDL particles. They can be removed again. So that cholesterol can come in and it can leave. However, once you have oxidized LDL particles, so this particle gets absorbed and then it will turn orange because it's reacted with a reactive form of oxygen, it's now going to stay. It is not going to be eliminated. And so now it may begin to accumulate in lipid plaques. So when people consider heart disease, often they don't think automatically of air pollution and stress and, smoking a little, but, these things which affect oxygen. But these reactive forms of oxygen, they change the lipid particles in a way that promotes the formation of plaques. Now, if there's a problem, white blood cells, go to the problem. But in this case, that's not necessarily what we want, because those macrophages can ingest those oxidized LDL particles and then just sit there as these big toxic bags of lipid, which we call foam cells. And if we ask what is making the plaque bigger, a lot of the plaque is composed of these white blood cells. And so more white blood cells coming to the area is not necessarily what we want. It's actually going to make these foam cells, which make the problem worse. And so we want to avoid macrophages coming to this site where they absorb all of these lipids and contribute to these plaques. But not only would environmental factors like, the amount of lipid be involved, or the oxygen which oxidizes the lipids, but also then we have all of these genes which are involved in the migration of macrophages to the blood vessel wall. And so, for example, the monocyte chemotactic protein, its name tells you it's involved in, monocytes, which are the precursors of macrophages, touching here and interacting with cell surface proteins. Once again, the big picture is it's complicated. If you're asking, why does patient A have lipid plaques developing and patient B doesn't? Well, you realize, wow, there's genes, there are genes there are genes for the oxidation of lipids, or genes for antioxidants made. But then there's all of these environmental factors as well, such as lipids and, air pollution, et cetera. And so once again, a big part of the problem is that monocytes can leave the blood and then go into the blood vessel lining, and where they ingest these oxidized LDL particles and then start to compose a lipid plaque. So earlier, when I was talking about the damage to the endothelial lining, so there are genes that can be expressed here. There are signs of damage which can encourage this cell to penetrate. Also, one of the proteins called the vascular cell adhesion molecule 1, VCAM1, androgens increase its expression, which means that in general, in male patients, macrophages are just a little more likely to leave the blood and go into the blood vessel lining, where they can promote plaques. Men do suffer from heart disease at an earlier age than women. Okay. So like I said, I have multiple videos that go through this. Once again, just trying to stress how complex all of this is. Most people don't consider white blood cells as part of the problem in heart disease. But once again, these macrophages, which become foam cells, they are a major factor. And so all of the both genetic and environmental factors which affect them are clearly important. Go to the next one. But there are more. And once again, for my classes, that's kind of the goal, all right? Not to memorize each and every piece of this, but to realize that just there's so many different aspects of this. So for example, some are purely environmental, all right? And so whether one smokes or not, clearly environmental, and there are all of these deleterious consequences of cigarette smoking, which will then promote heart disease risk. And so, this affects the level of inflammation, which can alter that endothelial lining and increase the likelihood that white blood cells come in, and increases blood pressure because of nicotine being a vasoconstrictor. This can damage endothelial cells more. It'll affect the clots, which we'll be talking about in just a second. So, cigarette smoking is clearly an aspect to this. And then there's so much more. So in some families, it's lipid issues and mutations in genes affecting lipid metabolism, which are the primary factors to consider in their heart disease risk. But in other families, it's the protein. Amino acids can be metabolized, and one of the metabolic products is this toxic form of homocysteine. Now, how much homocysteine we have can be affected by, vitamin deficiencies, and so that's clearly an environmental factor. But then one can also have a mutation in this gene, which converts methionine into homocysteine. And so some people have homocysteinuria. They don't have hypercholesterolemia, a mutation in a cholesterol-related gene, resulting in higher heart disease risk, but rather something involving proteins. Just a couple of other things. I'm talking about fat pretty loosely, but the reality is there are different fatty acids. Some fatty acids actually lessen inflammation and will reduce the risk of heart disease, while other fatty acids will promote inflammation and worsen the risk of heart disease. And so if you are ingesting fat, at some point then we have to discuss which fats, because some fats are easy to convert into a hormone, which will cause inflammation to get worse, while other fats can easily be converted into a hormone, which lessens inflammation. So not just fat in the diet, but which fat in the diet has to be considered. Adipose is a factor. As we gain weight, a problem can be that adipose cells send out signals. There are hormones and inflammatory signals which come from fat. Hormones like leptin, whose excess will make heart disease risk worse. Adipose cells can also then send out a host of inflammatory signals. So if inflammation will make heart disease worse, then look at all of the inflammatory signals which can be produced by fat cells. So, and forgive me, I apologize. So some of them can be produced by fat cells, and the others, adipose tissue can just have white blood cells there, and the white blood cells can produce these. So forgive me, not all of them are made by the fat cells themselves, but the adipose tissue and the white blood cells there. So the point is that here's another aspect. How much adipose do we have in our bodies? Have we gained weight? Because excess adipose, as is evident here, would then produce excess leptin and excess of those inflammatory signals, which would then worsen heart disease. And then it gets more complicated because it's not just adipose. Another question is, where is your adipose? So, first off, adipose can be put in the hypodermis, right, which is deep to the dermis, just deep to the skin. But it turns out that this subcutaneous adipose in different parts of the body can have different effects. So in general, it's often said that being pear-shaped has a better effect on heart disease risk than being apple-shaped. So if you were going to gain adipose, that gaining them, in certain parts of the body, so around the arms, around breast tissue, on thighs, that's actually preferable to the subcutaneous layer in the abdomen. Visceral fat is actually much worse. And so some adipose is actually inside the ventral body cavity. In the mesentery, around organs, that's actually a worse type of adipose, making other signals. Once again, if we were to just go through all of the different factors, we see that there are things in our diet which can lower heart disease risk, which can elevate heart disease risk. And so, various fruits and vegetables, they have antioxidants, they have lycopene, they have vitamin C, and so there are a whole host of dietary elements. Moderate alcohol consumption can lower heart disease risk. Now, that can vary in that, for example, what we do with alcohol varies in part based on our genes, our ethnic background. And so while one individual might have moderate alcohol consumption, which lowers their heart disease risk, another individual, their body doesn't metabolize alcohol well, and actually alcohol might raise their heart disease risk. So when we talk about risk factors, we have to realize that there's a whole host of things in the diet which can be contributing, either lessening the risk of heart disease or worsening it. If a blood vessel narrows to the point where a blood clot might get lodged there, or on the surface of the plaque, if collagen is exposed, that might stimulate platelets to actually form a clot. So here you see a platelet actually bound to collagen, and as a result, it's going to actually start a clot. Well, then we ask the question, how likely are you to clot your blood? And we realize, oh, well, that varies. If all of us were to stick our fingers and then take a little blood into a capillary tube, we would see that if we broke the capillary tube at say minute intervals, some of our blood would clot rather quickly, say in 1 to 2 minutes. Others, it might be 5 or 6 minutes. So some of us, our blood is much more likely to clot. Now that's good in that we're less likely to hemorrhage to death if we were to get cut. But it's bad in that if it's easy for clots to form, you are more likely to form clots inappropriately and then have a heart attack and a stroke. So many individuals after multiple heart attacks, they might take, quote, blood thinners, which reduce the number of clotting factors. But things like smoking, high-fat diets, weight gain, oral contraceptives, genetic variations in gender can influence the number of clotting factors in our blood. Blood pressure is the next topic, but essentially the same thing applies. As you realize, there's a lot of genetic variations for blood pressure. So for example, there's the ACE enzyme, the angiotensin converting enzyme. There are variations in our population. And as a result of this genetic variation, some of us are more likely to have higher blood pressure. But then in addition to diet, weight gain, other things like, nicotine and salt intake can increase blood pressure. So there are both genes and environmental factors which can affect heart disease risk. I mentioned that alcohol has an effect. And in addition to that, red wine and dark beer apparently have other components which can reduce heart disease risk more. So in addition to alcohol in moderate amounts having a beneficiary effects, there can be additional components in certain types of drinks. So obviously, you would like to be able to tell your patient whether they are at a high risk of heart disease. It is the #1 killer in the United States and in the world. It turns out, however, it's complicated because there's all of these environmental factors which are involved. So you could ask, what's your weight, what's your, fat intake, your cholesterol intake, what's your do you smoke, your exposure to air pollution, etc. But then there are genes. So for example, all of us have an apolipoprotein E gene, but we have different alleles, one from our mother, one from our father. And if you have the E4 combination, if each of your parents gave you the E4 form of apolipoprotein E, you're at a very high risk of both heart disease and Alzheimer's. And so there are genes involved. All right, some of the genes are involved in protein metabolism, some in lipid metabolism, some in attracting white blood cells to the endothelial lining, some in the production of reactive oxygen species, etc. And so, we have to consider these. If we say you carry a gene which is increasing risk, sometimes it then matters, well, how many genes? So for example, in this case, the individuals here in yellow, they have one LDL gene which is increasing their LDL numbers for the LDL receptor of mutation there. And so they have high LDL levels, more than 190. But if this patient in orange gets the mutant allele from each of their parents, they have very high LDL levels. And so not only is having the gene an issue, but do you have one copy of the gene or two? And so I'd like to teach this simply because a lot of people simply have, if you ask what causes heart disease, the #1 cause of death in the world. And for students who are going into healthcare, obviously something you want to study. A lot of people say, oh, it's your cholesterol. Now that's not wrong. But if we were to say, all right, well, let's compare, people from the, say, 1950s to today. What would, say, a 1950s person have had for breakfast? And I know I'm stereotyping. But, maybe bacon and eggs and lard and who knows else. But if we were to look at the amount of cholesterol in your modern diet, it's actually less than in the 1950s. So we have cut cholesterol from our diet significantly. What has happened to heart disease risk? It hasn't budged. It's about the same. So the point is, if you have this idea of heart disease, where it's this simple thing, oh, it's your cholesterol, period. Well, you're wrong. And now you're missing patients who are at a high risk. Forgive me, the numbers on this, I read different numbers. I'm just going to give a middle of the road value. Maybe 20%, maybe more, of the people who suffer from heart disease, the very first symptom that they show is that they have a heart attack and they die. That isn't good enough. You can't have that as be your first symptom. All right. In healthcare, you want to work with patients and make their outcomes better. But if the first sign that they have a condition is that they die, that's a really difficult disorder to treat. So we have to understand risk factors and be able to predict them. But here's the problem. There are so many risk factors because heart disease isn't one thing. Not everyone's heart disease is the same. This person has lipid issues, but it's a genetic factor that's affecting that. This other person has lipid issues, but it's lipids in their diet. But this other person, it's reactive oxygen species for a genetic reason. This other person, it's reactive oxygen species because of the air pollution, the smoking. So it's complex. And if we're to understand this number one cause of death in the world, we just have to understand that it is this multifactorial trait caused by multiple genes, multiple environmental factors, and very often the combinations matter. Which gene do you have with which environmental factor? That might make a difference. So the videos in this playlist go into much of that in greater detail. And this was just meant to be an overview showing the complexity of heart disease. Okay, Pete.